Hey guys, heart summary. Do know that the heart risk factors are smoking, alcohol, diabetes, and a certain lifestyle, namely being sedentary. Patients with diabetes, excess alcohol intake, and obesity are at increased risk of hypertension. Do know that diabetes mellitus and obesity are both risk factors that can lead to elevation of lipids, hyperlipidemia, which is elevation of any or all lipids, but we particularly care about low density lipoproteins in the serum, LDL. Do know the term aneurysm. Aneurysm is a localized weakening of the arterial wall, and you're going to see it either with your naked eyes or with a microscope as a bulging of the arterial wall. This bulging of the arterial wall results in coronary artery aneurysms in a disease called Kawasaki disease, which is an exam favorite and a childhood disease that is often associated with arterial wall inflammation. All right, I want you to know the term atherosclerosis. Atherus indicates porridge, sclerosis, hardening. Osis is a chronic condition. What we have here is over time a gradual buildup of atherosclerotic plaque, so a porridge-like substance with hardening in areas of the arteries, not veins. And if it's a damage to the blood vessels of the heart, we call it coronary artery disease. If it's the damage to the blood vessels of the brain, we call it cerebrovascular disease. Cerebrum stands for the brain. Now let's discuss two ways of damage to the heart muscle. So one would be a complete damage, complete blockade of the coronary artery, and we call it myocardial infarction, colloquially known as heart attack. And in the second scenario, we have an incomplete blockade of this very coronary artery, and we call that angina pectoris. For that, let's review the blood vessel and how platelets make a platelet plug, and then what happens after a platelet plug is formed. So let's review. Platelets are found in blood. Platelets do not stick to the blood vessel wall because it's covered with a non-stick material, and we call it endothelium. That endothelium is a non-stick material. Platelets don't stick to it very easily. So if that endothelium is damaged, platelets do stick to that damaged surface, and right after they form that platelet plug, start releasing chemicals which activate the clotting cascade, the coagulation cascade. And when that cascade is activated, fibrin is formed, and that fibrin stabilizes the platelet plug, and we call it thrombus formation. Now, what happens in myocardial infarction most of the time, there may be other reasons, but most of the time we see a rupture of the coronary artery atherosclerotic plaque. Let's remember that the blood vessel, the coronary artery, is not quite patent. Its lumen is already narrowed by that atherosclerotic plaque, sometimes narrowed to more than 70–80%. Right? So there is very little that you actually have to block off. And so when platelets bind to that protruding atherosclerotic plaque that protrudes into the blood vessel lumen, there is form a platelet plug, and a fibrin stabilizes that platelet plug. What may result is that the whole lumen is no longer patent. The whole lumen is occluded. If you have that occlusion of that whole luminal of the lumen, what you have is a complete blockade of the coronary artery, and we call it myocardial infarction. So basically, there is an atherosclerotic plaque rupture, exposure of atherosclerotic material, acute thrombosis, formation of the thrombus, and a prolonged ischemia that follows it because the lumen is no longer patent. And so heart muscle no longer gets blood. And if it doesn't get blood for long enough, cells start dying. How do the patients present? Patients present with a huge crushing chest pain. That chest pain radiates to the shoulder, to the jaw, and the left arm. And in a worst case scenario, heart no longer beats properly, so we get a cardiogenic shock. So it's a shock due to a heart problem, due to the heart problem generated by the heart, and patients present with profuse sweating and cold, clammy skin. So that was myocardial infarction, a complete blockade of the coronary artery. In case of an incomplete blockade of the coronary artery, what we have is angina pectoris. And angina pectoris presents with severe pain that comes and goes, and we call it recurrent. When does it come? It comes on exertion and goes away either with rest or with medications such as nitroglycerin. All right, so that chest pain is not as severe as the myocardial infarction chest pain, but it's identical in quality. It's just shorter in duration, and it goes away eventually. What is the chest pain like? So it's a severe chest pain, and it also radiates to the neck, the jaw, and left arm and upper abdomen. So both myocardial infarction and angina pectoris may radiate to the upper abdomen. So how do you treat myocardial infarction? How do you save the patient? There are multiple ways. You do need to know one. One would be PTCA, and the second one is CABG. No, PTCA stands for percutaneous transluminal coronary angioblood vessel plasty forming. So you're forming a lumen. What you want to do is get rid of the stenosis, the narrowing, or the obstruction in the blood vessel. How do you do it? You take an inflatable balloon that is attached at the tip of the catheter that has a stent around it, and you implant that stent to keep the blood vessel open, patent, all right? Patent. And its patency basically allows blood to flow, and you want to get rid of that stenotic area or the area where the thrombus just formed. Remember, we talked about a complete occlusion, the thrombus formation. You may also treat angina. Severe angina may be treated the same way, and now you're just getting rid of the plaque. Another way to treat patients would be coronary artery bypass graft CABG, which is a procedure to where you make a new route around the occlusion. So you have a damage here, you have a normal blood vessel here. This way is blocked, so you take a blood vessel segment of a saphenous vein. Notice it's a saphenous vein, which you really don't need in order to survive. And so you just bypass. You bypass that occlusion and bring blood to the area where blood is needed. And parts of the heart are now fully supplied by blood. Let's talk about heart failure. Now, heart failure means that heart is no longer capable of doing what it's supposed to do. It fails at it. Myocardial ischemia, lack of blood flow, and therefore nutrition and oxygen to the heart may cause it. Hypertension may cause it. Heart has to pump against greater pressure within the arteries. Valvular defects such as mitral insufficiency may cause it. In mitral insufficiency, for example, blood flows back from the left ventricle to the left atrium, whereas that mitral valve is supposed to keep the door shut, so as to say, and help the left ventricle to generate enough pressure to propel all that blood into the aorta. Infections may also cause problems with heart and cause heart failure. Do know the term cor pulmonale? It's frequently seen in literature, and that simply means that there is a heart failure, eventual heart failure, due to a disease of the lung disease, okay? In which case, the right side of the heart generally enlarges, the muscle of the heart generally enlarges, trying to pump against usually a greater pressure gradient in the pulmonary system. Normally that gradient is that pressure level is very low. So let's talk about what may damage the heart muscle, ventricular muscle, or problems with ventricular muscle. So when we see uncoordinated contractions of the ventricular muscle, we call it dysrhythmia. Ventricular fibrillation is commonly seen and is deadly, leads to death and unconsciousness. Why? Because the ventricle can't pump blood to the rest of the body, and so we require defibrillation. We require to apply electric current and CPR if we see flatline EKG. So do know the term atrial fibrillation. Don't confuse it with ventricular fibrillation. Atrial fibrillation is actually the most common type of arrhythmia in a clinical practice. And what we see here is uncoordinated atrial contractions. Remember that the atrial systole specifically means contraction of the systole. If we say systole in general, we mean ventricular systole. So what we have here is that there are uncoordinated contractions of the atrium. Blood doesn't flow to the left or the right ventricle, build clots within a left or the right atrium. There is an increased clot formation risk. And so depending on where that clot goes, we have either stroke if it's the left atrium, or we have a pulmonary embolism risk if it's the right atrium. Now let's talk about decreased ventricular contraction, where on the right side, once again, I really want to bring it home. Right-sided heart failure is cor pulmonale. Right-sided heart failure, failure due to a lung disease. I've just mentioned it earlier. It's really important. But what you do want to know here is that right ventricular heart failure, which is nothing else but the right heart failure, results in a congestion of all the blood vessels that bring blood to the heart. A congestion in all the blood vessels that bring blood to the heart. That would be superior vena cava, that would be inferior vena cava, and if you have that kind of a congestion, we call it a backward effect. And in a severe case, you're going to see, for example, ankle edema. We're going to have some more examples of that. Do know that decreased blood volume may also, hypovolemia, decreased blood volume may also result in heart failure. Heart has nothing to pump, no blood to pump. So ventricular filling, decreased ventricular filling, for example, when there is a severe valvular stenosis. So if there is a severe stenosis, not enough blood passes from the atrium into the ventricle, and that's like hypovolemia, decreased blood volume. Now let's go over the right heart failure again. I really want you to know it because what are the symptoms of right heart failure when the right side of the heart doesn't pump properly? Well, I already went over edema, ankle edema, right? We sometimes say pedal edema. Pes is a Greek for foot. So we may also have, so edema is accumulation of fluid between the cells of that part of the body. So when we have edema in the area of the foot, we call it pedal edema, ankle edema. But when we have accumulation of fluid in the area of the abdomen, we call it ascites. So patients have ascites and pedal edema due to a congestion and a backward effect, and both ascites and pedal edema are not the first thing that we see. We first have patients that are complaining of being tired. And then we see jugular venous distension. That's the distension of the vein that empties into the superior vena cava and is actually visible on the neck. So jugular venous distension, you may want to really, I showed it to you in the class. Jugular venous distension empties into the superior vena cava. So obviously it's not just the veins that are dilated, organs are dilated as well. Liver is dilated, hepatomegaly. Spleen is dilated, splenomegaly, or both are dilated, hepatosplenomegaly. Left heart failure is also the most common cause of right heart failure, because just as we talk about the backward effect, a backward effect for the left heart failure is congestion in the lungs. And when we see congestion in the lungs, we see pulmonary edema with resultant dyspnea, difficulty breathing. Patient is kind of suffocating when they lie down, orthopnea. Patients who fall asleep, suddenly wake up in the middle of the night and feel like they're suffocating, and that's called paroxysmal nocturnal at night dyspnea. So how do these patients with a left heart failure present other than this? Well, they do have fatigue as well, but they also have decreased urination, because when the left heart fails, less blood goes to the kidney. But we're talking about a severe left heart failure in this case. Also, if very advanced, in patients with left heart failure, we also have signs of right heart failure, which are listed above: jugular venous distension, hepatomegaly, splenomegaly, ascites, pedal edema. You should, when given a case, you should see, is it just the congestion on the right side that we see, or also signs of dyspnea and pulmonary congestion, in which case that would be the left heart failure. All right, let's talk about the systolic heart failure and diastolic heart failure. Systolic heart failure means heart can't pump properly. Diastolic heart failure means heart cannot fill up properly. In systolic heart failure, contraction is damaged. I showed you the picture. I showed you the dilated cardiomyopathy as an example. Muscles of the heart are incapable of pumping out, ejecting enough blood. And in diastolic heart failure, due to whatever reason, we have a decrease of relaxation. Now, I did show you a picture of the hypertrophic obstructive cardiomyopathy as an example of an athlete, for example, fainting and maybe potentially dying on the field. Do know that the coronary artery disease, coronary artery insufficiency, may cause ischemic cardiomyopathy, and therefore myocardial ischemia and death of the heart muscle, and muscle cells, myocytes, are not replaced. So they're going to be replaced by a scar tissue, the fibroblasts. And if it happens on the left, it's going to be a left heart failure. If it happens on the right, it's going to be the right heart failure. And we're going to see a backward effect and the congestion depending on which side is affected. So do know that the diastolic heart failure may be due to a myocardial ischemia and scarring of the heart. Do know the term high output heart failure. This is when a heart is normal, heart is absolutely normal, and heart is normal, but it's trying to keep up and cannot keep up with what is expected of it. There are many reasons why we have high output heart failure. Do know that the low output heart failure is not something that you really need to spend too much time on. It's very uncommon compared to the high output cardiac failure. It's found rarely in postoperative heart failure patients. All right, let me briefly review heart anatomy. You do know that myocardium is the muscle of the heart. You do know that on the inside is endocardium and on the outside is the pericardium. So endocardium is in direct contact with blood. Inflammation of the acute inflammation of the endocardium is called endocarditis. When this inflammation is due to bacteria, we call it bacterial endocarditis. Another name is infective endocarditis. Endocardium not only covers the inside of the heart wall, but also inside of the heart valves. And so bacterial endocarditis may actually cause a valvular damage. Most common valve affected being mitral valve. Let me explain you why so. This is a left atrium. This is the left ventricle. This is mitral valve. Now, the how it works is from left atrium, blood goes to the left ventricle and then to the aorta. When left atrium empties its blood into the left ventricle during systole, left ventricle tries to raise the pressure of the to pressure that is higher than found in the aorta and empty all that blood into the aorta. When mitral valve is damaged, raising that pressure inside the left ventricle becomes very difficult. That blood constantly spills back into the left atrium where the pressure is much lower than the left ventricular pressure in systole. And so over time, left ventricle is unable to cope with such a high demand and fails. Left ventricular failure, left atrium also enlarges, and this spills back into the lungs and causes right heart failure. All right, so which bacteria can cause bacterial endocarditis? You need to know streptococci, staphylococci are two. Staphylococci cause an acute happening right here, right now, rapid onset damage to any type of valves, but streptococci cause a very, what we call insidious damage, subacute damage. So it's a very gradual onset of damage, especially in valves that are previously damaged, for example, by IV drug use, believe it or not, even introduction of foreign bodies in the medical setting, such as pacemaker insertion, catheter insertion in the blood, procedures at the dentist's office are common causes, but also age is a risk factor. So streptococci cause a subacute bacterial endocarditis. Staphylococci cause acute bacterial endocarditis, and treatment for both is IV antibiotics for a very long duration of time, 4 to 6 weeks.